Good evening, everyone. Thank you for being here tonight. It's my pleasure to introduce Dr. Cheryl Park. She's currently the Director of Advanced Prosthodontics Program at USC, first female director, which I'm very excited. We've always been male, but we need a lady, which I'm very, very happy. She's a triple USC, meaning she went to college at USC, dental school, and residencies. I'm sure her loans are huge.
Don't for that.
She also maintained a private practice limited to pros in Glendale with her husband, Dr. Sang Byung, also a USC prosthodontist. She has a great lecture for us tonight. So please welcome Dr. Cheryl Park.
Yeah. Okay, so thank you for the invitation and the nice introduction. Yes, I come from, and I'll have some images up here, but I am very excited to be here, especially because Dr. Nguyen is one of our alumni, and I wanted to meet him. Unfortunately, I didn't really ever meet you in person, right? I've heard about him, but again, thank you very much. I do not have, I'm going to move this over so that I don't see. 1 second. I'm going to, let's see. I'll do this if that's okay. So you can see my slides. So no conflict of interest and unaltered images. I guess the bigger affiliation with me is the USC School of Dentistry, Advanced Prosthodontics. I took over the program now. It's about 2 years, making some changes to the program. So I am here to share those changes or related to those changes. I do see my patients in Glendale, California, with a bunch of other prosthodontists. So I just wanted to put that out there. I come from a very traditional program, which was very male dominated. You can see all of our 2 previous directors here, Dr. Donovan and Dr. Chi. And you know, I was very flattered when they came to me, would you direct the program now? It's time that, you know, everything changed over to update the program and just, you know, have someone new to run the program. So I was very glad. I knew it was going to be a challenging work, but I gladly accepted, and in fact, proven to be challenging, but I think I learned a lot from the experience. So now I get to train my own residents, and I'm still involved in implant dentistry with the pre-doc students with DDS program at USC. So I hope to share some information where we are with digital aspects of implant restorative dentistry. So I decided to focus more on that today. And then where we might go in the very near future, if not already in some practices. Aside from dentistry, me and my husband, we learned photography through dentistry, but we've expanded that. My husband really has a love for cameras and mechanisms about different cameras. So he and I like taking photos other than dental photos. So I sometimes go, you know, with my son to take some photographs of the street and with different cameras, and you can see you know, some of that here. I put this photo up there because really, I think coming from a prosthodontic restorative background, I feel that we are sometimes the architect that plans everything and then make sure that that comes through so that you can see the outcome that you are imagining. So that was kind of the construction. Other than dentistry also, I keep busy with my 2 dogs. They're like children to me. And I do have a little boy who is really everything to me. And I hope, you know, I don't complain a lot about dentistry, that he wants to be in our field. And because I really, even though there are hard days, I hope you agree with me that you have a passion for dentistry and all the updates and learning. Okay, so talking about updates, I think the major updates in dentistry really came from, you know, the big updates were not updates, but developments that really proved to be useful were fluoride, CBCT, of course, as well as dental implants, okay? And, you know, CAD/CAM, because it's out there. Digital dentistry is all over, it's surrounding us. It actually started with a dentist from Zurich, University of Zurich, which you see on the right side, and then an engineer. Okay, so hand in hand, they made this first CEREC scanner that was called the Lemon, and it took off from there. Okay, the companies bought over, but basically the beginning was this for the scanners. And now we have sophisticated mills, sophisticated scanners. So I'll talk a little bit more about that, focusing on implant dentistry. And it's amazing because now, Cher's side, supposedly you're able to mill a crown, a zirconia crown, and stain it and sinter it in about 20 to 30 minutes with the CEREC system. And so I'll focus today's lecture on the material changes specific to implant restorations, okay? And then how to deal with, or how we actually found it easier to deal with off-angled implants for restorations, as well as, okay, what is the actual practical way of fully digital workflow? Because everybody talks about that. But what is actually possible with fully digital, meaning castless? There's no cast, no physical cast at all, okay? Now, in the beginning of implants, it was interesting because we never started out just with single crowns, restoring single implant crowns, which is reversed because when I teach the dental students or cover their implant clinic, we're actually starting out with single crowns. So we actually started out when we discovered that the implants work or heal within the bone with full arches of edentulous patients, so we don't have to worry about extraction or existing infections. And then within that, there were even developments in terms of the material choices. And you can see here in this timeline that eventually, at first, we still use these type of metal acrylic type of teeth in certain instances, but eventually the metal became, instead of castable metal, we moved to millable titanium nowadays. So there was that CAD/CAM development along with the material choices that came hand in hand to where we are today for implant dentistry as well. And again, I'm going to kind of extract information for smaller restorations or partial edentulous situations, but really, depending on the material choices, on some patients that will have this kind of fractures or failures, okay? So this specifically is a titanium bar supporting acrylic teeth and denture teeth. So those on the maxilla, okay, will have these kind of fractures overall. So eventually, patients demanded more. Industry developed, so we went to try metal ceramic, which was very nice aesthetically. I think metal ceramic is actually, very predictable in terms of aesthetics. Dental technicians can work. So here you see a metal ceramic implant restoration on the maxilla. Okay, but the problem was when you don't have something soft on the mandible, then you might have that maxillary feldspathic porcelain fracturing off. So in some cases, we actually provided this titanium base and acrylic teeth still with pairing to the metal ceramic on the maxillary implants. And the conventional workflow that we talk about with our residents are that you take a physical impression, make a cast, and your lab technician does the wax up. And again, this is for the conventional metal ceramic workflow, where they might cut back that wax up, predicting where you want the porcelain. Okay, and then that metal frame is cast. And depending on whatever system of implants that you're using, it may be slightly different than casting in one piece or using different design before the porcelain. Okay, and we had very, nice results, very predictable. This is a partial edentulous. Two centrals are missing on this teenager or early teen or late teens, actually, skateboarding accident. So we came a long way, except, and I'm going to show one more nice case here with the metal ceramic, except in some patients, we would get porcelain fracture. Okay, and they would be pricey for the patient, pricey for us, again, if it happens in a very short period of time. So that was always a risk. And overall, I think with the development of zirconia or milled restorations, we've tried to convert these cases towards the different material. Okay, so here you see a full arch metal ceramic against metal ceramic on implants. And because the patients lack that proprioception with implants, they will not know that they're going to bite so hard that they will fracture these feldspathic porcelain. So what do you do if the patient returns before a year, maybe a couple months down the road that you're delivered a restoration and they come back, I want a different restoration. And you can't just bond on and repair these. So that's why I think because of these limiting factors in many ways, and because CAD/CAM dentistry, digital dentistry was so developed, we were able to slowly transition into a higher type of higher strength ceramic called zirconia, which typically is called 3Y-TZP, which is the original, more opaque type of zirconia, tends to be stronger. Nowadays, industry has wanted to go ahead and develop a translucent zirconia, which then it does compromise on the strength overall. So at first, we even experimented with millable lithium disilicate. And because they are weaker than metal, we do need to consider using these metal abutments, where these crowns are going to be milled with the hole, and that would fit right onto the metal abutment. Okay, and you can still keep it screw retained. However, what we found was with lithium disilicate, because it is a lower strength ceramic, that it might have problems on the road if you are using it for multiple arches or multiple splinted restorations. Maybe for a single molar still does the job, right? However, you never want to connect directly to the implant itself, whether it be internal with the whatever ceramic that you're using, lithium disilicate or the zirconia. You don't want to do a direct connection usually, because studies have shown and reports have come out that it would result in fracture. Okay, yes, it is high strength, but it has problems when it's directly connected. That's why we need that metal tie base, the industry call it, that metal abutment that you still need to cement the millable ceramics on. What happens in a internal implant fixture, they found residues of the ceramic and residues of the titanium. Okay, what happens in the external system of the implant platform is that you actually damage the external part of that titanium, because titanium is softer than compared to, let's say, high strength zirconia. You know, what else we found was if you do connect directly and there's, you know, those friction and wear of those titanium particles, it'll leach out into the gum area, the gingiva, cause a titanium tattoo, let's say. Okay, so we really want to avoid that. I know some labs still, you know, provide this type of design, but it could be a little bit of a risk for the clinician. And then when we initially went into these zirconia type of restorations, we had to think of design, okay? Because we're transitioning between metal ceramic to zirconia, even though zirconia is more of a tooth color material, that you still have that opaqueness though, okay? So people were thinking, okay, let's go ahead and layer the whole thing just like metal ceramic, and of course you're gonna get the same type of fracture. Okay, even more because it's really not less compatible. The bond between the metal and feldspathic porcelain, it's stronger than what it is with the zirconia. So we found out that even though the framework of zirconia would survive, the success rate over time would be very, very minimum, as you can see here. So now the trend is that if you do, and this is another example of a poorly designed, let's say, of a zirconia, and obviously you can see that the only zirconia that we see is in the middle right here. Very small amount of the framework, and everything is porcelain, so what do you expect, right? And people have tried different designs, even they have tried the zirconia framework, and because they like the lithium disilicate, the EMAX, they had gone ahead and cemented or milled single units of EMAX for a full arch and cemented that, which, you know, great, but that's a lot of risk for me for failure, okay? So nowadays, what was predictable for more than a decade of treatment in the program, was these type of designs where you can cut back on the facial end if you wanted to use a stronger opaque zirconia, and then layer on that facial end. And this works great if it's a at least a 6 unit, okay, or a full arch. For a single unit, they can still match, but it really depends on the technician's abilities to match the aesthetics and the color. So a design STL such as this, where you still want the context and the layering, right? Because you have that freedom of adjusting, maybe sending it back for additions. All the functional areas, as you can see here, all the occlusion, it should be in monolithic zirconia, which is a stronger one. And you can see that all the way up to the incisal edge is that stronger zirconia material. Okay, so that worked for us for many years, and this is the try-in of that framework of a different patient. And there was a learning curve from the lab component or lab counterparts as well, because at first they couldn't really manage the designing part on the CAD program. So they had thought, okay, it's better if they mill out these softer zirconia discs and gone ahead and cut back with the burr manually. And there were a lot of maybe broken zirconia at this stage before the final sintering. It's very soft, so you don't want to do that. The lab technicians were great; they were able to handle it. But again, we found that we don't have to do that anymore. Okay. Again, in some labs over the years, they prefer that we try in what's called a prototype that's milled or pressed even, and then they would actually manually cut back that area for porcelain, just like how we manually cut back the wax up for metal ceramic. And then they would try to scan that, mill it, and then layer it. Nowadays, with the residency and even outside, what we're dealing with is we're asking this type of cutback, and we provide a template. Okay, it should be this way for the lab technicians to go ahead and design and cut back on the software alone. And we found that you don't need all these mamelons. They really don't improve the aesthetics. It's the layering and the technician's ability that would improve the aesthetics there. So it allows us to treat very high function patients. This patient was a longtime bruxer. She came to us in her 50s, and she had worn away all of her teeth to the pulp or through the pulp already, had multiple infections, collapsed bite, you name it, super eruption. No space at all. So in this case, although we're all for development and zirconia and the high strength, in this case, when it's a high function patient, you really don't want a hard material against a hard material. So what we still do believe, try to minimize the risk, we'd rather have the patient wear through at least one arch softer material like a denture teeth or acrylic that's put on titanium metal. So we still do use that type of prosthesis. So this patient, we actually fortunately had a follow-up, and what we found out over the years, of course, the acrylic does wear because she is very high function. However, the zirconia on the maxilla really stayed very nicely and pristine. It has wear though, against the acrylic teeth, which the patient realizes that we can go ahead and resurface. 8 years follow-up, still, some wear, but not enough to invest and resurface the whole mandibular teeth. And these, at this time, was individual denture teeth on acrylic. So now there's even more of a development, which when it comes out, I will talk about for that metal acrylic type of prosthesis. Again, this is one of the older example where you'll see metal ceramic still. We have that same principle. This patient had a lot of root decays. Medication, anxiety kept her away from the dentist and had a lot of those root decays that needed really to convert to implant restorations. And again, originally when we thought of metal ceramic too, to avoid breakage of that maxillary beautiful metal ceramic restorations on implant, we would make these prototypes and GC pattern resin, and then go ahead and have the lab copy and mill that in titanium. And on top of that, there would be acrylic and denture teeth layered on. Okay, this is just by registration. So what has changed in terms of this type of titanium bar and framework and the denture teeth and acrylic is that because we would get sometimes denture teeth popping off of the prosthesis, and those would be also expensive, we've moved on to design, digitally, and then also providing a full arch milled acrylic teeth, so millable acrylic teeth instead of a denture teeth. So it's in one piece, and then the lab is able to provide the pink portion with either pink acrylic or pink composite, depending on the lab's ability. Okay, so everything, even in terms of the thickness that we would need, because for the acrylic, even though it's milled, it's stronger, you would still need at least 3 millimeters of thickness in the functional portion for it not to break. Okay, so a lot of these developments, even though we're using essentially titanium and acrylic, things have changed in terms of millable restorations. Okay, so this is an example. We still want to keep the titanium against the tissue whenever possible if the patient lets us, because that's the most favorable for the tissue when you have to use these type of combinations. Zirconia, by the way, is very favorable for the tissue, so we really don't mind if it's zirconia contact. It's even more favorable than any porcelain, similar to titanium. So again, we go back to this patient who has less than a year, has broken her metal ceramic, the layered porcelain part. And so for those patients, we do convert them to zirconia with these type of framework design. At that time, if I wish, I would actually have made all these tissue contact in zirconia and then layered only the facial part of that. And again, when we deal with more of a full arch or at least one symmetrical segment of teeth, these come in very predictably aesthetically. Pros and cons of zirconia prosthesis, especially when it comes to larger restorations, are that they have advantages and disadvantages. One, they can provide good aesthetics. There's no, right now, I think all the technicians or most of technicians are familiar with this product. Even the generations of zirconia have improved with the same strength. However, if these have actual framework fractures, we cannot cut and solder, right? We can't put it back together. So still unable to do the fractured framework repair. So they can be expensive. However, those framework of zirconias tend to not actually fracture unless you design it a certain way. Superior strength. So the flexural strength of this is about 1200 if you use the original high strength zirconia. And you do need to design it such that you don't have functional areas layered still, because you will have chipping if it is layered, just like metal ceramic. And it is wear compatible. So polished zirconia is actually very wear compatible to the opposing dentition. And however, there's also, when you have zirconia on implants against zirconia on implants, the patients will hear the osteoconduction and complain maybe they have clicking in their head every time they come together. So that was actually big on the patient's part. So still we have that, I guess, a niche for that titanium and softer milled teeth. Advantages of the digital files can be stored in case of any future mills that you have to do. Less long-term data though, and scientific data, and according to systematic reviews. Although I would say in terms of in the program, we've used zirconia and titanium millable restorations for a while now. I would say for zirconia about more than 10 years. And we haven't really seen those catastrophic failures or fractures. Favorable tissue response, I've said that. And so reduced laboratory costs. That used to be big in terms of, I guess, when we thought of metal ceramic, because sometimes these longer metal frameworks costed us actually some pennyweights. There would be another cost associated with the gold or the precious metal. So in terms of that, there's less, but I have been seeing that the laboratories have been catching up in their fee schedule per unit. So it's really not, I don't think this would be a true advantage at this time. Now, there's a big limitation in terms of, again, you never may deal with this, but sometimes you do have too much restorative space for zirconia as a material. Because these come in pre-made thicknesses that are milled out, okay? In some cases that we have been seeing where the patient had their mandibulectomy because of a cancer, and they had put in the fibular graft. And in those cases where there's too much space, okay, we do have a limitation. Okay, so the final limit or the maximum amount of restorative space you can think of is 26 millimeters, okay? Because the disc that is actually the max height of 32 millimeters on most of the reputable brands, okay, they actually shrink when you final sinter it about 25%. Okay, so when you look at a patient with a lot of resorption and you're thinking about these type of materials, there is a limitation in space. Now, when we discuss implant restorative space or space for restorations, the older article that we would always quote is this, okay? And it wasn't quite directly said in a chart form. So I thought it would be a good idea to update this from a more recent article, okay, Carpentieri et al. And they listed out in a table format very nicely about the vertical space limitations or requirements for different type of restorations. And this is great because if you actually go into the article, they can summarize more and describe more of each of the processes that require these space, okay? So just more information out there for you. Now, design factors, okay? What we learned is that you can't deliver with this material. Okay, so in situations that you have very resorbed posterior ridge on the mandible, if you wanted to use zirconia, I would highly not recommend it because you might get actual framework fractures such as this. Okay, sometimes because around implants, we do have to make some of the cross-sectional areas thin around that implant abutment. We might get fractures. We have seen fractures. So what we have found through experimenting was that you need at least 0.5 thickness of zirconia around that cylinder at the very thinnest part. And nowadays, conveniently, we can actually tell that because we can simply ask the lab technicians to provide the thickness in various regions. And they should be, discussing with you about the design when it comes to any implant or restorations done digitally. Because what could go wrong, we found that you can get fractured zirconia, and then you can get fractured zirconia but not debonded. Okay, so these are various examples. And finally, again, if you directly connect the zirconia with the implant, you will get these fractures initiating and eventually fracturing off the framework. Okay. So although it was a big step forward for dentistry or implant dentistry, I would say, it was very tricky in figuring out all the nuances. So therefore, although we say, okay, you can use this abutment to zirconia, sometimes we have another tricky situation or factor where you have to choose your abutment that will support the cemented zirconia. Okay, I'm talking about screw retain restoration overall, but your zirconia that's milled with the hole for the screw retention has to have this middle piece where it's cemented on. And depending on certain company or systems within a same company, design of that cylinder mattered because you don't want debonding of the zirconia off of this type of abutment. Again, although we found significant differences in terms of how we could avoid layering fractures, we find that when it comes to literature and the evidence, when they did a recent systematic review about monolithic zirconia single unit, multiple unit crowns, they found that we still have limited evidence. So they followed up, they chose the studies that followed up at least for 5 years. And for crowns that are single units and crowns that are in multiple units or FPD, okay, these are the cumulative survival rate, okay? So pretty good. However, they at the end concluded all this data surmounted to, for a short term, less than 5 years, excellent for both single crowns and FPDs, survival rate, okay? Again, success, survival may be a little bit different, but for medium-term survival, which is more than 5 years, still we're lacking in literature, okay? Maybe clinicians and industry and the lab have been moving forward a little bit faster. So maybe if we actually put in the data, this data would be there that could support this is, you know, a medium-term good survival, but at least for the studies that are available, still lacking, unfortunately. So in terms of abutment choices, because the shorter abutments that the companies actually offer, such as Straumann, they have their vario bases that you can provide your lab for these type of zirconia to be cemented on. What we have done when these tie bases weren't available at all in the market, we have been using sometimes the stock temporary cylinders. For those implants that are placed in the right position that you don't need angle change, this works great. The final screw though, if it's a different screw, then you do need to switch out to the final screw to torque. Okay, so these were in the right angulation. We don't need angle change. Then we were able to get by with using a temporary cylinder. Again, I guess cost effectiveness for the clinician, but again, Straumann, their abutment screw would be the final one. For other systems that are not the final one, then you would have to switch the screw to the final. And you can see the design here again of that layering, the limited layering on the facial. And I'll show you the outcome so you can actually see. So this is how the patient came in, and I won't go into too much of the detail about the actual cases, but the patient actually had some infection, heavily restored dentition from 8, 9, and 10, endodontic treatment, previous epico, and also post and core crown on there that were flared out. Patient really didn't like that, and again, reinfection caused the patient to come in, and she wanted to actually change some of the adjacent teeth with veneers along with these 3 teeth that weren't really serving her for function or aesthetics. So again, in that limited situation where it's not the full 6 units, can we get aesthetic match, right? So with the technicians, the right technician experience, you can, but it could be tricky because the veneers that you see on 6, 7, and 11, they're very minimal. So it could be very tricky, but can be done nowadays because they have been working with the staining and with this material for a while. And what else we found was with this, again, there's even, you know, more details of the design because we have to use this tie base. We can't just directly make some shape and connect that. So what we have found was for subcrestal implants, for whatever reason, your surgeon, you had left, you know, deep subcrestal, which happens. We don't want to necessarily risk that biologic price by profiling everything out, okay? Because you might also damage some of the tissue there. So in those cases, we had to, even to seat the restoration, we had to modify the submucosal contour, the subcritical contour, as you see here, okay? In that, we actually studied, okay, does this significant polishing modification of the shape near this thin region, does that damage or does that affect the strength of these restorations? So when we actually tested in vitro, it resulted in that if you have at least 0.5 thickness around that metal cylinder, you were okay, okay? So that modification and polishing was okay if you expected about 0.5 thickness at the end of that polishing. So now what we do, because the lab technicians cannot see the radiographs and say, oh, this is subcrestal, I'm gonna make it a little bit more linear or skinny. They actually guess, right, from your soft tissue. Now we can actually provide, and some labs actually may have this, but they can provide a diagram. You can just check off, okay, what do you expect in terms of convex, more linear contour, or how it might come out until the emergence of the crown. Or simply, sometimes we would send just the picture of the radiograph without any patient information, although the lab can have that communication with you, okay, in order to save clinical time too, okay, and save that additional factor that would make you adjust in and out for the patient, which is very uncomfortable. So that all of those inventions, along with CAD/CAM, along with the materials, now allows us to think of full arch with X number of implants, minimum as much as possible, in order to provide and convert the patient with failing dentition with implants. And sometimes you like to keep the teeth around until the end so that it can serve as a fixed provisional. And then when that's converted fully, you can see the radiograph with the temporary cylinders. At the provisional stage, we can extract the remaining teeth in between. And really, it gives us predictable results so far, okay? And even, I'm kind of deviating, but even on teeth-based materials, there has been more advances that we're comfortable now using zirconia or millable ceramic in order to convert these long span. I guess the clinician decided to use many abutments in order to retain one of number 25 as a Maryland bridge option. So the patient was really inflamed around the tissue and wanted a little bit more aesthetic. So nowadays we're comfortable. Again, we're cautious when it comes to retaining these zirconia solely by bonding, but we're comfortable in order to provide the patient a Maryland bridge with one wing. Okay, so going back to implants on a different topic, how do we deal with off-angled implants, and has that changed over the last decade? Okay. I'm thinking it's very hard to, after eating, to stay focused at this time of the evening, but thank you for your attention. I see everyone's eyes. So how do we deal with this? Because we can cement retain. We can do a custom abutment and cement retain. There are issues with that. There's also space that you need for those type of stacking up the materials. But how do we deal with this? Can we actually screw retain? What did we do back then and what has changed over the decade, right? Okay, so why avoid cemented crowns? And most of us have heard this maybe a couple years ago, why avoid cemented crowns, okay? But I still do see them out there. And in some cases, you can't avoid them, which I agree. But they do cause a lot of soft tissue problem, okay? So this was a young dental school student that has come to us that he knows from implant classes that, you know, he's kind of ashamed that he has this implant cemented on and it's actually become loose during the time in his senior year. So he wanted to do something about it for number 9. When we took a look at the loose crown, it turns out they had a double jeopardy. They had used the zirconia directly connected to the implant, which didn't fracture internally, thankfully. But again, because the zirconia abutment that you see here was so short, okay, the crown on top of that had loosened up, lost retention. And because they had cemented, we could see the cement residue remaining here. We actually had more, but by the time we took it out for the pictures, that was it. And that could have very much bad consequences around the implants over a long period of time. So that's why we don't like to cement retain whenever possible. So when we have an off-angled implant, one of the solutions back in the day, and maybe even today in certain situations, were to use these pre-angled abutments or abutments that would provide angle change, okay? Doable. However, what we're dealing with, a couple of limitations, again, disclosures, where they're pre-angled. So the amount of angle change is set depending on the company's component. So on this particular one, it has to be turned at least 17 degrees. okay? And then what we call elbow happens, which means because in order to turn the degrees, the angulation, what happens is there becomes a thicker part of the abutment, and usually in the aesthetic area, that if the implant is shallow, then that metal component will show, right? Which really limits us, okay? So in this example of a wax up, actually, the original implant comes out incisal-facially of number 11, okay? And then if it's a deep enough implant, then we can use this pre-angled abutments, and you can see the elbow there, and then convert that to the lingual side, the whole of the access hole to the lingual side. So that was okay for certain cases. However, you still deal with 2 screws. So one screw would be to screw down the abutment to the implant. The other screw would be to screw down your restoration to the abutment. So, you know, the second screw is smaller, has less torque. We had problems when it comes to multiple angulation that you have to turn, okay? Where the patient may have loosening of the smaller retaining screw over time. And then when these angled abutments have loosened up and turned, you have to actually figure out what the orientation was that would fit the original restoration. So we had problems. Now we learned about—
Dr. Park,
Yes.
we're going to launch our 7:30 poll.
Okay, so there's going to be a 7:30 poll. I'm going to go ahead and pause for a moment.
If you're able to advance through the slides, you can feel free to and continue your presentation.
Let me try to move this out of the way, which I don't think I could. Yeah, or well, as a host, can you move it towards one of the sides?
I'm not able to move it on your screen, unfortunately.
Okay.
We'll just wait for we'll wait for about 2 minutes here.
Sure. I guess in person you don't have to do the poll. I'm glad it's not a quiz about.
We may start doing pop quiz.
Yeah, I was thinking I never submitted any quiz questions.
Okay, we've got just about 30 seconds left in the poll. If you haven't voted yet, please do.
Yeah, in person, I believe you don't have to worry about it. And sorry if I'm yelling because I have only one ear that hears my own voice, so I'm trying to make sure.
Okay, the poll is now ending. Thank you.
Okay. Okay, so back to some of the alternate or updated angulation or re-angulation solutions is that we have the original company that had come up with this idea, which wasn't really new. It was new in dentistry, but again, mechanically, it wasn't new. Had come up with this dynamic abutment solutions. What it is, and you probably may have used it or come across it or have heard about it, is that they would use a special titanium base that would have a shorter wall on one side, okay? And then they would use a special, let me see. Oh, let me go back, I'm sorry. Okay, special screw that allows the special screw driver tip to enter and screw in and out off of the long axis of the implant, okay? And again, I think the video visual is more clear than explaining that in the mouthful. But again, essentially, you're able to screw in and out add the change angulation without being straight on screwing in and out, okay? So that requires, though, the special design, shorter wall on the side that you're going to change the angulation to for the tie base, and special screw and special screwdriver tip. Well, dentistry, what happens is that every company comes out with their own, okay? So we now have biotech, third companies coming out with the same solution, which makes sure that we are able to purchase theirs slightly different design. So again, this is one of the Strawman where they have this special screw that for the bone level, specifically for this photo here, where they would have the special screw, okay? That's marked green. It also has all of their angulated solution has an AS at the end of their component names, and a special hexalobular, they call it, at the screwdriver tip. And obviously you can see that one of the side of that cylinder titanium base is shorter, okay? So, but this was a major change. Apart from zirconia coming in the market, this angle solution was a major change. So again, many companies came out with their own. So you can see on the left-hand side, this is actually from an article. I thought I put the reference there, but maybe not. But this is the dynamic solution, which was the original. The second one from the left side is the DDS, which is the third-party implant component solutions. And then the third one is actually from Nobel, their angulated component, which, I'm thinking zirconia is gonna pop right off, okay, because there's no retention wall, okay? And then that's compared in this particular article to a universal base, which is just straight on, so that you can see with usually what happens is we have to screw in and out straight on. But because of these systems, we're able to angle change and screw in and out at the off angle, okay? And again, various designs of their own angulated systems, various screws. So I think in terms of consumer aspect or my patients, when we have multiple implants that need, maybe two of the implants need change of angulation, and you're mixing up angulated screws with regular screws, it's very, very critical for us clinicians to document at least what kind of screw, what was the final torque, what was the material inside that chimney. All right, so finally, implant case. What do we do? Patient walks in with an implant already healed. It always heals in a bad position. And then the problem is very shallow, right? Shallow facially, you can already see that grayness, and no one can do anything about it because the patient already had previous grafting. It was actually the first implant failed, and they had put another implant in there. This is an Astra EB, very shallow. So the only solution was, instead of using any of the angled abutments, which would be horrendous and show that metal margin, to use these angulated solutions to bring the chimney back to the lingual side. Still, shallow implant, you cannot go back from that, okay? So anything depth-wise for the implant, you wanna be at least 3 to 5 millimeters in aesthetic zones as compared to the attachment to the adjacent teeth, okay? Okay, so another case where the patient had an implant done in his early 20s. Now early 20s or teens actually, because of an accident. And now he saw that there's a discrepancy between his other teeth and the shorter implant crown. Okay, what happens is in some patients, and this happens to be a male, they have a growth spurt or they grow. People actually change over time. They age and remodel, or until their late 20s, males can actually have this growth where the implant is fixed and ankylosed in place. So the crown actually becomes shorter, okay, especially in the anterior region. So he had wanted to change that. And I knew from the cemented crown that probably it will be an off-angled implant. And not surprisingly, when I tried to just go through the incisal, I happened to find where the screw access was with the custom abutment, remove that, lots of cement. And then when I put in the impression coping, Voila. Okay, so very off-angled incisal-facial on a young patient. Okay, thankfully there weren't really a high smile, so they didn't really show it. But again, you know, you want to provide the best aesthetic result. So again, this is a provisional where the hole wasn't corrected yet, and it comes out right in the facial incisal. Okay, so when it is corrected, in this case, I think I've used the dynamic abutment, the original angle change abutment, and I've, you know, followed that facial layering only. So the green design that you see is all zirconia, and the lab knows that they need to use a stronger zirconia for me. So I think considering that we use the stronger zirconia and just the facial layering, the outcome was pretty good. Okay, so from the occlusal aspect, you can see how opaque and white it looks on that number 8. However, when the technician has worked with the layering and the staining, they're able to match that coloring pretty well. Okay, pretty well. Okay. Now, I will get to the last part of the presentation, which is of really my interest as a program director, where you know, we're looking into literature and if there's actual evidence behind for implant restorative workflow, a full digital workflow, meaning there's no physical cast. Okay, so in that we have to break down that question: what is an implant workflow, right? And how is a digital workflow different? Okay, so what I found was that, and you know, I really had to curate all the articles for the residents because I don't want them to get lost, and I wanted you know, find out what evidence was there, right? So in my mind, the digital implant workflow splits between here, where yes, we can actually predictably place implants digitally through the guided surgery systems, right? Many guided systems out there. But is it really predictable for implants from the time the impression is good to go for impression? And what does that mean, right? A digital workflow for implants, right? That means that we're thinking about either intraoral scanning, or if you do a physical impression, maybe you can lab scan that cast. A little bit less digital, but again, those are the options. And then the CAD stage, okay? How do you actually digitally articulate for patients that are edentulous? And then how do you depend on models? Because a lot of the times nowadays, again, if you say digital, there is a model printed, okay? And there, for implants, we haven't actually have been predictably moving towards this solution. And I'll talk about that with more images. And then, are we okay with the internal spacer that the lab is providing if it's fully digital? And how's the fit, right? If it's a tooth and if it's an implant, right? How's the fit to the type base, okay? And then finally, we come to the CAM stage where we're thinking about, okay, what are the materials that you can CAM, okay? Or you can machine or mill. Can we use printed material as a final definitive, okay? Or are we still bound to milling? So different material choices. So when we had to break this down and actually translate into the clinical side, it was a little bit of a headache. But what I can kind of break this down with you is that, again, when we're talking about fully digital workflow for implants, we have this piece called intraoral scan body. And this article actually goes over many different brands of it. And they have actually, stationed off different parts into the top portion being scan region, and body is the middle portion and the base. And the base, what we found is depending on the material, okay? The fit of these scan bodies can vary on the implant, right? So for example, we see here some of the scan bodies are in metal, right, in their base. So that provides a better fit, for example, than the ones that are fully made of softer PEEK material, okay? So that was another variable that we had to think of. Okay, what kind of scan body are you using? And And then we come to the scanning portion. Now you've attached the scan body to the implants. You're ready to go with scanning. And this is one of our past residents. And now, do we know what type of technology is behind your scanner, right? So for intraoral scanners, there's 3 predominant mechanisms of scanning, okay? So at the scanner tip, one popular one was the triangulation technology, which is used by all of those Medit OmniCams, Carestream Dental Wings, and Planmeca Emerald, okay? On top of that, another popular technology was the confocal microscopy. Again, this is the tip of the intraoral scanning, okay, where Trios, okay, and iTero and PrimeScan scanners would use this technology. If you notice from CIRAC, they used to use OmniCam, and even their older scans were one technology, which is the triangulation. But they found that Trios is actually using this technology, and it's slightly more accurate in terms of that data that they were getting. So in their latest version of the PrimeScan, they switched over technology, which is pretty rare unless they saw a significant difference for a company like that, right? So we know that Trios, when we did the literature research about how they compared different technology, and this is the last one, which is called the active wavefront technology at the tip of the scanner. We found that oftentimes Trios had kind of the more consistent accuracy, okay? Again, there's many studies out there, but the peer-reviewed ones actually said Trios, but many other ones were acceptable too. PrimeScan was another very predictable, very accurate one. And again, when I'm talking about accuracy, it divides into trueness and precision, where trueness means, are you getting the same target that you wanted every time? Precision, are you just hitting the same marks every time? Okay, so we actually want to combine both. We want to be at the bullseye every time, being precise, and true, being accurate. Okay, turns out even how you scan also matters, right? Scan sequence, nobody has come up with, okay, this is the best sequence. You're going to go ahead and do the occlusal first, buccal, lingual. Nobody, there's no consistency. What I would recommend is following that scanner manufacturer's guideline, because they probably had tested out, and that was the result in the literatures. When you have a misscan or missing information or a noise in the scan, they even tested out in this group, Revi alone, they've tested out, does it matter if I cut out, erase that portion, and then go ahead and rescan? Or do I just overscan it, which is easier for us, right? And I used to do this all the time. And again, I'm not sure if I'm going to actually follow this because of that convenience factor, where they did find if you actually erase and cut out part and scan it to add everything together, that would be more accurate than overscanning the error, okay? But again, how much does that play into accuracy? We don't know, because all these factors that I'm talking about are the steps or different steps that things can go wrong with the digital workflow, okay? As we know, for conventional workflow, we know that there's shrinkage, there's expansion, there's misfits, right? So we know that, but we're going into digital errors that could accrue, okay? So now, what I think is more predictable for fully digital workflow is a single unit, okay? And you can try this for the posterior. In particular here, I'm using a Dynamic Solution scan body, and they have 2 parts of their scan bodies. Again, I don't have any conflict of interest, but I just find that this is kind of predictable for my patients or my workflow, where there's a scan adapter portion, which is the metal portion that's screwed in, okay, that you can radiograph if you are in doubt of the fit, okay? And then you can go ahead and snap in the scan body, the peak scan body portion, which is actually magnetically connected to this metal first adapter. And this is useful because they come in different heights, the metal adapter. And what happens is you intraorally scan the opposing arch and the arch that you are trying to restore. And then you are able to have the lab design the crown. Okay, and I actually asked for a provisional because at this time I didn't know if it was actually possible. So there's no cast, and we go ahead and mill out from this design alone, trusting in the scan body accuracy. Okay, and again, this is single unit, so we don't have to add on that question mark of, okay, what is the passivity here, okay, for multiple units. So for a single unit, it's predictable if you have a reason to go ahead and mill the provisional so that you can refine anything that is off. So, you know, some because of contour or any of the contours you can trim, and then you rescan that to relate to the lab for the final prosthesis design. And this has been pretty predictable for single units. I'm comfortable. So I moved all the residents for single unit cases. If they wanted to learn the digital workflow, this is the way that we do it. Okay. Again, this is one of the past resident case where they are using that scan adapter and scanned the scan body. And now it's kind of crazy because we have to look at the CAD portion and give them feedback because the residents for their exercise, they're designing on their own on the software. So I'm giving feedback, okay, this looks off. And they actually have a worse time with the digital designing. It's actually quite hard unless you're used to it, like the lab technicians. So finally, we were able to try in a provisional and restore the patient. Okay, so now how is the complete arch situation? Are you able to do an intraoral scanning and fully digital workflow? Answer is not yet. Even though there's ways around it and you see people talk about it out there, one way that you could go about a full arch if you wanted to do a digital scanning is that you use these fiduciary stickers that this author have used. And then they would also have a previous, I guess, temporary provisional that they can merge where the teeth positions are. Okay, again, not full digital. So I don't think at this time, full digital is possible with full arch or multiple teeth or multiple implants. Now, the tricky part is if you say, how come then, how can we go into digital? Can we use a printed model, okay, for the implant so that we have something physical, right? So what we can do is print the model. However, because with the implants, you need a digital analog, we call it, or the industry calls it, okay, which is this kind of analog that is supposed to fit into this hole that was printed in the model. Whenever you're connecting those two pieces, there's a little bit of give. There's always room for error, okay? So this is the RC bone level Strawman, and this is our resident trying to do this. When our residents were testing this out on a printed model, we tried to verify the fit between the implants with various methods still. So again, accuracy, and I'll go into several different factors and we'll conclude today. But again, with printed models though, over time, they might change in color, they might distort. And this is showing that latest distortion over time. So they do a color map, they scan models in sunlight for how many days, after no sunlight and storage for how many days, and they saw that over time printed models do distort. So I would say you want to use that printed model if it needs accuracy within a month, okay? Angulation also matter. I just want to mention that, depending accuracy, printer choice matters, okay? So our resident went ahead and printed different abstract models, and they, using a software, they combined or simultaneously looked at how deviating that's from the master model, okay? And the choice of printer actually matters. We use Asiga, Formlabs, as well as Sprint Ray, and we found that at least for this limited in vitro study, that Formlabs was pretty more accurate than the others, okay? So the type of printer also matters. So again, a lot of digital development, but are we better in terms of controlling the error, right? So CAD variables, we're getting there to the CAM, but CAD variables also matters. And I'll mention that even if you use different softwares and also different softwares recommend different internal spaces for your millable restorations, they don't come out the same way. The internal spaces differ than your design that the lab technicians may have planned. So you might have noticed also zirconia, we talked about that shrinkage that happens with the final sintering. So the fit has to be there. So you need to have a good lab technician that will do quality control because of these so many variables, okay? This is another study we're showing that with FPDs, even more errors, and they tested more different softwares that could have, when they merge it to the original model, they had different internal fit and marginal errors, okay? And then this is, let me go. Again, different softwares, same internal space for an inlay that was actually milled, cemented onto in vitro teeth, and section for micro CT had different gaps, okay? So at the end of the day, every step for workflows, digital workflow actually adds onto that error, okay? Going back to my previous resident case where they had successfully went ahead and designed the provisional, okay, with the digital analog in place. Okay, we were able to actually verify the accuracy of the multiple implants. So we actually delivered the provisional. However, it was a printed provisional and was pretty weak. So around the cylinder, it would have emergency of breakage. And really, when it comes to multiple implants and teeth adjacent to those implants that needed to be prepped for some type of layered or EMAX pressed ceramic, the lab support wasn't there. They didn't really feel comfortable with a full digital workflow. So at the end of the day, really how much are we better, or how fully digital can we go, right? These are some exciting things in the literature about virtual articulation. Of course, there's a COIS system, or the school of thought with their devices. And then one of the articles that I want to highlight here is the first one, LEPID, and they talk about various updates of how people tried virtual articulation. So that's a dense read, but if you ever wanted to, that's a good read, okay? And that's one of the ways that they had said was that you can actually use a cone beam CT to get the Porion as a reference and then superimpose that to the articulator, okay? So exciting times though, okay? Not perfect, but exciting times. The most, I guess, sophisticated way of registering the jaw, and this is like the pantograph, right? So the real motion jaw tracing is the mod jaw system. However, when I looked into this in the for my residency, it was very much pricey, okay? So where the patient is calibrated with the headpiece and a mouth gear, and they move their jaw. So the result was pretty accurate, okay? But in real life, that cost associated with it, I don't know how much clinicians will be able to afford that or have enough use with that much of a correct jaw movement, okay? This is kind of a hack that they did and actually published about using QR codes to do the same jaw registration or jaw motion tracking, where they had flaws though, because they were using a single camera lens of a phone. So a lot of people are looking into this. Again, I don't know how much that impacts us in the clinic, because would this really eliminate any occlusal adjustment, right? Which I don't think so, because of the other errors that might come. Milling, there's variables. We all know that multiple axis is better, more accurate, but we also found out the ceramic type on the 5-axis really doesn't influence the accuracy, still accurate with whatever ceramic it is. And then, tool deterioration. So as technicians mill, if the tools deteriorate over time, will it affect the clinical quality of the millable restorations? It turns out no, because the software would actually stop you and tell you, okay, this is too worn, go ahead and change the burrs, okay? So those are some of the CAM variables. Of course, calibration is big too. So with all that said, what does all this mean? okay? Because I need to translate that, right? We need to find the right path from what we have clinically and what we have in the literature. It means that case selection. So you can do a fully digital if you're selecting the posterior single unit case. However, you do need to know where the error occurs so that you can limit the errors as much as possible. The big one that really limits us is the laboratory support. Are they digital, right? I can scan all I want, send it to the lab. If the opposing lab does not know what to do with it or handles it wrong, it's gonna come with accumulated error, okay? So last bit is that we will see more of what's called photogrammetry. And this diagram from this article explains it well, which is the other arm of digital along with the intraoral scanning that I just talked about, okay? Where they use a coordinate system and they have their special cameras with 2 lenses to calculate out multiple implant position, and they're pretty accurate. Okay. However, the drawback is that you actually need to intraoral scan as well for the soft tissue information. Okay. So again, this diagram is showing how you can go intraoral scanning way or the PIC camera or the flag coordinate system. You still need intraoral scanning for the tissue, and then that would result in merging of the data and then the CAD/CAM process. Okay, so that's kind of the latest digital workflow for the implant, which may not be possible if you're worrying like me about the accuracy. In the future, again, using the system that I use, what I foresee with any different systems is that we're going to rely, rather than lab scanning of a cast, maybe we're going to rely more on the intraoral scanning for limited cases. And then if you're using scan body, that's great. And you can either decide to use a digital analog on a printed model, or there's another reverse where you can attach, if you have a provisional, if you have something that you want to reverse scan, you can attach the scanner log towards the provisional and then scan that in order to obtain the same model digitally. So that would be maybe predicting that that becomes more convenient or accurate is where we stand today, okay? What I see more and more in the future, and even now when we're seeing patients in our program, is that we have a lot of miscellaneous implants, okay? So a lot of patients now come with problems with existing implants and we don't know what it is, okay? So that's another factor that kind of worries me, or I guess it's exciting that you can expand on it. Again, I see that, you know, we're going to try to develop this fully digital workflow. And if I do maybe lecture in the future about this, then that might have become more predictable than now. And then additive manufacturing, there's a lot of things out there that promise the resolution of a final restoration. One example is from Split Ray, Onyx Inc. They promise definitive prosthesis. So that could be maybe refined. And then finally, maybe for those miscellaneous implants, we're trying to test out, can we use some type of software to use that artificial intelligence of matching up implant libraries, not just the radiographs, but matching up the actual shapes of the libraries to have AI tell us what that could be, right? So that could make it easy for us. That was it. Thank you for your attention. And if any questions, you can find me here or through Dr. Nguyen. So the question is, sometimes there's a large gap created when you're dealing with implant restorations adjacent to a tooth. I actually tell the patient ahead of time because I do expect a gap. We can't, if there's a big undercut on the adjacent teeth, we can't expect to fill that with the implant restoration. It's not healthy. So they know of that limitation. There's some degree you can close it. Okay. Well, okay. So the implant is supposed to be ankylosed. Okay. So there must be some kind of tooth movement or remodeling. So Although we don't see that often. I hope you're not seeing that often, right? So when that happens, I think I would just explain it to the patient that this is so, and hopefully this is not in a short amount of time, okay? Okay, so then maybe their dentition is not stable, okay? So we're talking about gap that's created over time between the implant restoration that you have placed and that's solid, and the adjacent tooth, the actual contact gap. I have seen it once, and really we can't explain it because we know that the implant is ankylosed. Yeah. So again, for the audience, I think Dr. Nguyen had commented that he sees it in a very end tooth, terminal dentition, and that may be because the tooth itself is moving, it's not stable, and sometimes we need to actually take off the implant restorations and take a look at what kind of remedy or addition that we can do. And I would actually notice the difference in two. So we're talking about the case with younger patient, you place an implant that's ankylosed in the anterior, and then you slowly see that the implant tooth is shorter than the adjacent anterior teeth. So that's due to probably growth, okay? So to the patient, you don't want, that molar patient with the gap, you don't want to explain that, oh, you've grown, right? So you do want to kind of distinguish what could happen, right? Why do we get such space sometimes in different patients? Okay, thank you. Let me see. Okay, full arch fixed implant prosthesis has the hygiene problem to clear the implants. How do we deal with this? Do you do a hater bar metal clip system for removal prosthesis and a fixed implant connector? So the major full arch implant restorations were fixed that I talked about for here. In terms of the hater bar, I think those are the overdenture removable prosthesis. Those are the options, but I don't think those will be quite the same functional service for the patient, because you still have that space that you need, and you still have that metal housing inside of the denture type of prosthesis. So again, I don't think there's a straight answer for this.
Thank you, Dr. Park.
No problem.
For your presentation.